My name is Anna. I'm an AIRS ambassador, and I'm here tonight for AIRS. We're going to be talking about all things innovation in breast radiology, oncology. So we are going to have a special guest tonight. Okay, she just joined us, Dr. Asal Rahimi, and I hope I'm saying her name right. I will get it in just a second. So let's add her as, oh, here we go. She already requested. It's loading. Give us just a second. Yay! You did it!
Good. How are you? It looks like I'm a little blurry here.
Yeah, do you want to see if you can like just wipe the screen just a little bit? Because it looks like your lighting's good. I'm getting like a little bit of a glare, but
Let's try it just a little bit.
perfect. We're getting ready, guys, and we're gonna dig into, yeah, I think that's a little bit better.
A little bit better. Okay.
Yay! Well, I'm glad we're here. Thank you so much for joining us tonight. I had just introduced that I'm here on the AIRS Foundation page, and we have you here as our guest tonight, Dr. Asal Rahimi. Am I saying your name right? I want to make sure I get it. Okay. Okay, hang on. Your audio cut out on us there for a second. Can you speak for me again? Just make sure we can hear you. Okay, we're not hearing you.
Okay, there you go. I can hear you now.
Yay. Okay, she's back. Awesome. All right. So we are here tonight, and I have a little bio for you here real fast. And then I'd love for you to actually kind of introduce yourself and tell us a little bit more about what you practice and your specialty before we dive in. But for those of you that just joined, we're going to be talking about innovations in radiation oncology tonight. Dr. Rahimi is here. She is an expert in this area. You are a professor at Department of Radiation Oncology and the Chief of Breast Radiation, Associate Vice Chair of Program Development, and the Medical Director of Simmons Cancer Center Clinical Research Office at UT Southwestern Medical Center. Is that correct?
Yes, perfect. Thank you so much. So,
amazing.
Summed it up, but so I'm a board certified radiation oncologist. I specialize in breast cancer. So essentially like 95% of my practice is treating breast cancer patients from, early stage 0 to stage 4 metastatic breast cancer. And as a radiation oncologist, a lot of people will kind of mix that up with a radiologist. It's very different. Radiologists are the doctors that actually read X-rays and CT scans and ultrasounds and do some of those procedures as well. As a radiation oncologist, I'm in charge of the radiation portion of cancer treatments. So the medical oncologist does all of the chemotherapy and kind of more of like the infusions and oral medications and intravenous medications that kind of go through an IV or into the vessels. And then the radiation oncologist oversees the radiation portion of cancer treatments. So that's what I specialize in, is in breast cancer of radiation.
Well, thank you for breaking it down, because you're right. The terms are very similar. And when you get into the cancer space, it can be very overwhelming because you see so many different people. And so keeping track of who does which things and who to turn to can be really overwhelming. So that's super helpful to understand. And talk to us a little bit before we jump into kind of the innovations in where we're going. And maybe this will be part of our discussion, but each situation in cancer type and cancer case is so unique. How right now and then moving forward are radiation oncologists like yourself determining who's a good candidate for radiation, and how does that kind of fit into the treatment plan?
Yeah, so I think it's very variable. Obviously, like the more research that we have done over the years and the decades, the more we're learning about breast cancer, and the more we're learning there's different types of breast cancer. And so kind of to break it down in very, very generalized terms, if most women that opt to undergo what we call breast conservation therapy, which means saving the breast and not doing a mastectomy.
Hmm.
The majority, not all of them, but the majority of them will usually have some type of radiation involved in their treatment. So
Okay.
that's kind of the trade-off. If you want to save the breast, then usually radiation is a portion of that treatment. Again, in very generalized terms, there are some situations where we wouldn't do it, but in very general terms. With mastectomy, um, it depends on how extensive the disease is. So if it's earlier stage disease without lymph node involvement, a lot of times the mastectomy can be enough with or without chemotherapy or like anti-hormonal therapy.
Hmm.
And a lot of times you don't need to have radiation, but if you do have lymph nodes involved, then a lot of times we actually do need to recommend radiation. And then the radiation oncologist will assess kind of different risk factors like how many lymph nodes are involved and other high risk factors to determine if radiation needs to be a part of the treatment course or not.
That makes perfect sense. And I'm sure with everything, there's kind of the risk reward that you're weighing, right? Because radiation can be super helpful in these cases, but also you're weighing kind of what's the impact to the body, right?
Right. Exactly. So, yeah, I mean, we would only recommend radiation if there's, I mean, typically what I use in my practice is like a 15% benefit,
Mm,
um, like less than a 15% benefit, then, we typically will kind of talk about that as like 10 to 15% kind of being more in the gray zone of, you can probably go either way, but if it's less than 10% benefit, then radiation probably isn't warranted. And then the risks outweigh the benefits. So we would not recommend radiation at that circumstance.
that's
But
super helpful to understand because I think a lot of, AIRS patients and people that I come into contact with are questioning, why did you have radiation and I didn't? Or why did I have it and you didn't? And it's helpful to understand a little of the nuances there. So let's jump into a little bit of the kind of innovations. It seems like there's exciting new things coming out in terms of how radiation is approached and minimizing some of those risks as well. Talk to me about this breath hold radiation
yeah,
on the left side specifically.
yeah. So one of the ways that we used to do radiation, we didn't have like advanced imaging. It was just like really kind of plain film 2D X-rays. And we, as radiation oncologists, we would just bring a beam coming this way and one coming this way tangentially. And you were kind of just hoping you missed the heart. I mean, this was, 50 years ago. That's how they did it. And I would say probably until like probably about 3 or 4 decades ago, things started changing as we got more sophisticated imaging with CT scans
Mm,
where we do 3D imaging. And then we could actually see where the heart was. So the main thing is with breast cancer treatments, you really want to make sure you have a good grasp of where the heart is and how close it is to the chest wall, which is the area that we're going to be irradiating. And there's techniques that we can use to move the breast and the chest wall away from the radiation beam so that we can really minimize the dose that the heart is getting. And one of those techniques is a breath hold technique where we have patients take a big deep breath for 30 seconds and then they hold the breath. And then essentially what that does is it expands the lungs with air. And as the lungs expand with air, the diaphragm moves down, the chest wall moves forward, the heart moves back and down. And when we come in with those tangential beams like this, the heart is just completely moved out of the way for those 30 seconds while the patient is taking a breath hold. Um,
wow.
and so, I think that this is a very important part of breast radiation especially for the left side. And even we in our practice even do it a lot of times for the right side if we're treating some of the lymph nodes. Um, and essentially, we try to do these techniques to really minimize the dose to the heart so that we can reduce the risk of developing coronary artery disease. And the very modern techniques that we have today are very, very good at really, really minimizing the dose to the heart, to getting them to doses where the risk of heart disease is very extremely low, which I think is different than kind of what it was, 4 decades ago. And so that is where a lot of, radiation did get a bad reputation in the breast cancer world because we didn't have the sophisticated techniques that we do. So I have a lot of patients that come and are scared because of side effects that they saw their mother or their grandmother have.
Yeah.
But today, the way we deliver radiation is very different than we did several decades ago.
That's amazing. I mean, it seems like you said such drastic changes over the years because of the imaging, because of the ability to be more precise. So that is really great to hear. Have you heard any kind of feedback and experience from any patients that are now kind of going through radiation
Yeah,
with these type of techniques?
yeah. So, I mean, it does require the patient to hold their breath for 30 seconds. And oftentimes, like 5 to 6 to 7 times every day when they come in for, the 15 or 20 minutes that we're delivering the radiation. And so, we ask our patients to practice this before we actually start
Mm,
our first treatment because, it's not a normal thing to do like one breath hold after another. So you kind of have to build up a stamina. But we have women that are in their 80s that can easily do this once they kind of practice that. So I think a little bit at first, it seems overwhelming and it's a little bit awkward, but most people are able to surprise themselves that they are able to do this successfully. Um, the other thing is, I think it's really important to have a team of radiation oncologists and therapists that are savvy to how to do this because there's different technologies that can monitor these breath holds. Hi there.
sorry, sorry, I had a visitor. You wanted to learn about radiation
That's
oncology.
we like little visitors. Uh, So I do think that it does take a specialized team. So the radiation therapist, it's important that they have experience with this and the entire team. In our practice, we have specialized technology where we're monitoring basically the patient's body to the millimeter, and we're monitoring it in like 6 different directions.
Wow.
So like minuscule movement that they're making, we're able to monitor this and make sure that, it is extremely precise. And if it is imprecise, we turn the radiation beam off. So it's only turned on when it's in the when the patient and the body of the patient is in the perfect position and the chest wall is in a perfect position. And when it's not, the beam is turned off. So it does take a
Wow.
expertise to, get a team that is privy to this and knows how to do this. But I think many, more and more centers are able to do this. But it's something that I think patients should be educated about so that they can make sure that they're, getting the best treatments for themselves.
Yeah, that's such a great point because, even if maybe the place you go to doesn't do that, you can be asking and bringing up these things. There's usually studies and reports on the benefits of them, and that kind of helps everyone as well. So that's so wonderful to hear. Apologies for my
Oh, he
interruption if
was
you wanted
here.
to join us. um, let's kind of transition a little bit into this concept of partial breast radiation as a post-op
Yes.
versus kind of, I know sometimes people are doing it pre-op, but talk to us a
Yeah.
little bit about that as another technique.
So the standard of care for the last 50 to 60 years has been to do radiation after surgery. And the standard of care has been to do like 6.5 weeks of radiation.
Yeah.
So 33 treatments, 30 to 33 treatments. And that's been the standard of care. Over the last 2 decades, I would say, probably like early 2000s, the field started looking at partial breast radiation. So instead of treating the entire breast, kind of more
Hmm.
focusing it on where the surgeon removes the tumor and the surrounding tissue, and basically just pinpointing that area. So there's a lot of benefits to doing that. Number one, you are treating a lot less tissue.
Yeah.
Breast tissue. Number two, you're getting less dose to the heart, to the lungs, to the ribs, to the skin. And so, there's potentially less side effects in doing that. Um, and so the initial trials have been doing it for 5 consecutive days, twice a day. And
Okay.
this is more for early stage breast cancer. If it's like later stage, it typically might require the whole breast or sometimes lymph nodes. Um,
Mm-hmm.
the early stage breast cancer that's hormone positive, we can just kind of pinpoint it and do a partial breast technique. Since
Wow.
the last 2 decades, there has been newer studies that have come out. Specifically, now it's the standard of care is to do it in 5 treatments.
Okay.
Um, and we have done it at our center. We had a clinical trial that we started the clinical trial, and it was doing it in 1 treatment
Wow.
post-operatively, which is really great. And there's some other centers that are doing it intraoperatively. They have an intraoperative radiation machine. It's mostly done in Europe. There are several centers in the United States that offer that, and they can do the 1 dose of radiation at the time of the surgery. So then, patients can hopefully be done with the radiation after they get out of the surgery.
I mean, that is just
Um,
phenomenal to think about, like the quality of life and the impact on their quality of life following the surgery and cancer treatment. Because I do know, like you said before, so many people are going through these months long of kind of radiation, and that I hear there can be a lot of fatigue kind of connected with that as well. Are you seeing improvements in kind of the side effects of radiation as
yeah,
well when you're doing less radiation?
definitely. I mean, I think, volume is everything. So the more area that you're treating, the more the side effects, and the smaller the
Mm,
area that you treat, the more, the easier it is going to be to tolerate it and to have less, you'll have less side effects. And I mean, I think many women just drive themselves and they take a couple hours off in the morning or in the afternoon to do their treatment, and then they just go back to work, and it's
yeah.
it's less disruptive to do it this way. And I think that has been kind of our main pull. And even now with the preoperative, we're even becoming way more advanced. And we can talk a little bit more about that. But the main thing is that, a lot of these treatments are so taxing on society in general,
Mm,
right? Just,
mm,
women that stay-at-home moms, women that are working and having a career, taking time away from family or taking time away from their career or taking time away from whatever it is that they're doing. I mean, it has such a financial toxicity against society.
oh, oh,
So
absolutely.
trying to make these easier treatments and still maintaining really high outcomes and low toxicity. And I
That's
see,
so, yeah, absolutely. I was going to say, do you want to touch on that question of kind of the
yeah,
lymph nodes?
yeah. So can radiation therapy be used in treating lymph nodes in place of lymph node removal? So not right now. So right now so the answer to that is kind of mixed, yes and no.
Mm,
Um, so right now, a lot of places where there's actually a large clinical trial that's ongoing, in which they're doing what we call a sentinel lymph node biopsy. The standard of care when
yeah.
you have a positive lymph node is to do an axillary dissection, which means the surgeon goes in and removes as many lymph nodes as they can see in the armpit area. So that can be
Hmm.
6, 7, 10, 15 lymph nodes.
Yeah.
The downfall of doing that is that it can cause something called lymphedema. There's a higher risk of developing lymphedema, which is
Hmm.
um, like swelling of the arm. So there is a large randomized clinical trial that's ongoing in the country. We're just waiting for the data to mature, in
Hmm.
which they, instead of doing they actually randomized women to axillary lymph node dissection for women that had positive lymph nodes after chemotherapy, or doing a sentinel lymph node biopsy. And what a sentinel lymph node biopsy is the surgeon at the time of surgery will inject dye into either the nipple or the tumor, and then that blue dye will travel to the lymph nodes, and that's usually the first lymph node that it travels to, and then they will just kind of do a little biopsy. They'll remove those 1 or 2 or 3 lymph nodes, and the pathologist will just look at those lymph nodes under the microscope and see if they're involved or not. And so in this
Interesting.
clinical trial, they randomized women to getting the axillary lymph node dissection if they had a positive lymph node, or the sentinel lymph node biopsy. Um, well, there's several trials. One that just did that for kind of upfront surgery. It was called the Amorose trial. And all the women got radiation. And what they found was that if women had up to 3 lymph nodes, they could do the radiation and omit the axillary dissection.
Wow.
And that really helped with reducing the risk of lymphedema. The ongoing trial that has not been published yet is the one that was looking at women that had chemotherapy up front and still had a positive lymph node after chemotherapy. And so we'll get the
Mm-hmm.
result of that. So I think that in certain circumstances, the data is looking optimistic in that we can use radiation instead of surgery, axillary dissection for kind of earlier stage disease with like up to 3 lymph nodes. But still, if somebody is going to have a lot of lymph nodes, more than 3 lymph nodes involved, it probably still does require an axillary dissection.
Wow, that's amazing. Again, just all these areas of research that are kind of moving forward so much. That's
Yeah,
amazing. And that the studies are going on right now. So maybe we'll get some new
yeah,
information. I know San Antonio Breast Cancer Symposium is next week too. So I'm just like always waiting for like what new studies
yeah.
are going to come out and what new information will we have that probably you all as professionals are kind of in the loop a little bit, but it's exciting for patients and organizations to kind of hear what's new and up and coming. So you mentioned kind of, we were talking about the post-op option of kind of what we were talking about, and then you briefly mentioned the pre-op
Yes.
radiation. How is that different, or what would be a scenario, where someone might do that as opposed to the post-op
So the
route?
preoperative radiation for breast cancer is absolutely not standard of care right now.
Okay.
Um, however, in saying that, there are a couple institutions in the world that are looking at this, including us at UT Southwestern,
Okay.
and we have a clinical trial that we reported. Was it? I think last. I'm getting the like years and everything mixed up. I can't
Blending
recall if it was last.
together.
There's been like so much that has happened in the last year. It's either last October or the October before that at our large Astro meeting, which is our large international meeting. And essentially, um, it's for early stage breast cancer, hormone positive. And what we were trying to do with this trial is deliver 1 dose of radiation, start people on their anti-hormone therapy, and then not do the surgery, delay the surgery like up to 1 year, and
Mm,
then hoping that when they go back for surgery at that, 9 months, 10 months, 12 months, whatever it is, that all the tumor would be gone. And we had different doses
interesting.
because this is a new concept. So part of this is figuring out what dose what dose is going to be good to do this for. Um,
Yeah.
and so we had 3 different doses, and they're very high doses, but because we're doing the radiation up front, the volume of tissue that we're treating is much, much smaller than if we were to do this even after surgery with partial breast. So in general, like a breast would be like 1,000 cc's.
Okay.
So we would treat the entire breast, about 1,000 cc's with whole breast radiation. In general, partial breast radiation after surgery would be about 100 cc's.
Okay.
If we do pre-op radiation before surgery and treat the tumor itself, we're treating about 10 cc's. So you can
Wow.
see this is a super pinpointed, exact
Yeah.
area we're treating, and we're giving a really high dose because we're able to, because it's such a small area. And that's what we looked at in our phase 1 trial, was making sure that we could safely do this. The secondary output was what was the outcome of this.
Yeah.
And in our second dose cohort, what we found, and it's published only in abstract form, not in manuscript form yet, is that we were able to eradicate the tumor, so to get the tumor completely gone, or have only like 1 or 2 millimeters of disease left in 93% of the patients, which it was
93%.
really,
Wow.
yeah, really extraordinary. So like it was like 47% completely gone, and then the other 47% roughly 47%. There was like 1 to 2 millimeters of disease, which means that we probably just needed a couple more weeks and the tumor would have been completely gone. These are tumors,
Yeah.
10, 12, 15, 20, 25 millimeters, up to 30 millimeters
Wow.
before them. So super, super exciting because this tells us that there may be a possibility where we can just treat with 1 dose of radiation and maybe in the future even eliminate surgery if we
Wow.
can get rid of the tumor with radiation.
That would
So
be
yeah,
unbelievable. Now,
so
when you were talking about kind of it's this smaller pinpoint area, are you only, just to clarify, you're doing it in one session? So
one
they're
day,
also not, wow. So I mean, not, you're then gaining two things because you're not having to do it for an extended period of time,
right.
and you're potentially either changing the type of surgery or removing surgery from the requirements based on your kind of the size of the
The whole
tumor. Wow.
this is that there's so many women that don't have access to care because,
Yeah.
one, they might live in a remote area in the United States that, it's a small town, the closest radiation oncology facility is 200 miles away.
Mhm.
They don't have transportation. There's many different reasons, or somebody can't come for, 2 weeks of treatment or 1 week of treatment or 6 weeks of treatment. So number one, we want to increase the access to care for
Yeah.
patients. And not only in the United States, but like think of places like Africa that don't have a lot of
Yeah.
radiation genes. In some of these countries, they have only like one linear accelerator in the entire country, and women have to travel thousands of miles.
Oh
So
my
the concept
gosh.
is that we can figure out a way where these women can go that way and get their 1 day of radiation
Wow.
cure it. Again, we have a lot of things that we need to do before that can be proven.
Yeah.
But this is a great start. We look forward to publishing this manuscript next year, hopefully. And
Wow.
we got a large grant from the state of Texas, several $1 million to start our phase 2 trial, which is going
Amazing.
to answer a couple more questions upon the same concept. So we're kind of building on this concept. And one of the things that we're going to be looking at is how to assess the lymph nodes. So I partnered with Dr. Bashak Dogan. She's she's a radiologist that specializes in breast cancer. Oh, can you clarify the pre-surgery radiation therapy you've done is before or after chemotherapy? Okay, so I'll get back to that.
Yeah, we'll come
And then
back.
Lori is going to be looking at translational. He's going to be looking at the tissue. So we're getting biopsies before and after.
Wow.
And what we try to do with these biopsies and blood work is try to predict who can be a complete responder, like try to predict from the tissue or the blood who's going to be a good candidate for this and whose tumors are going to respond completely to this or who's not, right? And then we don't treat.
Yeah.
So that's kind of what we're working on right now.
That's amazing.
So the question, can you clarify the pre-surgery radiation? Is it done before or after chemotherapy? So these are typically patients that don't require chemotherapy. So they're usually early
Ah, okay.
stage breast cancer patients that are lymph node negative, and just hormone positive breast cancer
Hormone
patients.
positive breast cancer.
Yeah,
Okay.
but in saying that, we do have another clinical trial that's in conjunction with Cornell, the Celldex trial, and we're doing the radiation kind of upfront with immunotherapy. This is a different concept, but upfront with
Mm,
immunotherapy
yeah.
and some other, and then doing like 3 doses of radiation and then trying to get the tumor to shrink. Totally different concept, but then they come back and get whole breast radiation. So there's like different concepts that are kind of flying around, but the one that we're working on is solely for node negative, hormone positive, early stage breast cancer. Um,
Wow.
so yeah, that's what we're doing. And there's a lot of other aspects to that trial, like trying to figure out, lymph nodes, because if they're not getting surgery for 12 months, you want to make sure that the lymph nodes really are negative. So Dr. Dogan is going to be doing kind of a non-operative lymph node biopsy up front.
Oh, wow. Okay.
Yeah.
I
Yeah.
mean
And
that,
the
oh, go ahead.
at Cornell. So the person that is the principal investigator of that trial that I was talking about at Cornell is
Yeah.
Dr. Sylvia Formenti. She's the radiation oncologist there. Um, so you can ask them about that trial. Dr.
That
Sylvia, her name.
That's amazing. I mean, it's just so crazy that all of this is happening, like you said, in this year or the last couple years. And just to think, like, what are the impacts going to be on radiation oncology, kind of best practices or standard of care in just a couple years? Not to mention, I love that you brought up kind of how does this affect global treatment and areas where there's kind of pockets of no access to care. I think, being on the board for AIRS, that, we serve a lot of women that don't have access to doctors for breast reconstruction as well. So it's kind of working backwards. If we're able to if surgery doesn't even have to happen in the first place, if we're able to minimize the impact of their treatment on them financially, on their
Mhm.
quality of life, on their job, they don't have to take off work. There's so many elements to that. So I love that you kind of talked about it holistically as well. It's not just the physical implications, but kind of the holistic piece as
Right.
well.
It's there's a lot that, goes into all of this. And, thankfully, like early stage breast cancer is highly curable. So I think from a field perspective, we need to look at how do we make these treatments easier, and are we over treating some of these patients, and how can we make these treatments easier, right?
Yeah.
And later stage, what can we do to improve it? And that may require adding more treatments onto what we're already doing. So, it's a very mixed bag, and
Mm-hmm.
breast is a very heterogeneous disease. And so we really have to kind of break it down and look at all the different types, and come up with the best plans and best ideas for all of these different scenarios.
That's such a good point because all of these scenarios are so different that I would assume you have to go through these clinical trials and testing for these subsets within the different types of breast cancer to then be able to say, okay, someone's coming to us hormone positive, no lymph node involvement, early stage, great. Now our standard course of care is X. And then we're going to have to begin the testing, first for another route, right? Is that kind of how the horizon of the research would go?
Yeah, I mean, I think research is it's very slow, but at the same time very fast, right? Because the other thing is, in the United States, we have such tough regulations that things don't change, like overnight. Just to get like a drug approved, there's so much that has to go into it with FDA approval and going through the appropriate phase 1 clinical trials and IRBs and phase 2 and phase 3.
Yeah.
So we have a very rigorous system in the United States. It's probably more rigorous than some other countries, but I think for good reason. But we also spend a lot of money in the United States on healthcare and research. So I mean, the future looks very bright. It's very exciting. We have a lot of amazing, scientists and practitioners. And I would just tell the public, we have to continue to support the science and the scientists, and the people that are in the lab doing these things, and the medical doctors that are running these clinical trials, so that we can continue to advance science for our next generation, for our children and for their
Yeah.
children. So I think it's very
Yes. And participating in
Oh,
clinical trials. Eris
I
and I
mean,
are just talking about that.
yeah,
What would be your words of wisdom,
yeah.
to patients as well,
Well,
thinking about
I
participating?
tell my patients that they're giving a gift to the next generation. So by participating in a clinical trial, you're not just doing it for yourself, but you're doing it for thousands of patients. Because if one doctor reads that study that you participated in, that one doctor is going to affect thousands of patients. Now,
Yeah.
if that same study is read, by 1,000 or 10,000 doctors all over the world, 20,000 doctors, imagine how many patients you're going to be affecting. And so the power of participating in a clinical trial, it's one of those things that is exponential, and doesn't just go for that one trial, because that trial will then spin off, and we'll learn something from that trial, and then the next scientist is going to learn something from that, and then it kind of just compounds on each other. So it's
Wow.
an amazing gift to humanity to to participate in a clinical trial, and it's something that's very, very important that, you know, we all should do and consider when we can, obviously.
Yeah.
And
Well, I love the kind of the spin you put on it because I know it can be just a little overwhelming, to first be diagnosed and then be kind of met with, well, what about clinical trials and these options? But it really is so powerful. And I know for some of our later stage breast cancer patients, clinical trials are also an amazing route sometimes to try kind of new or I don't want to say untested, but kind of experimental treatment options as
right,
well, right? And so some of these areas where you're seeing innovation and movement could be really promising for that, like you said, the next generation, and unfortunately, the cancer patients that will come after us as well.
right.
Wow. Well, it seems like we have so many promising things moving forward, which is great. I think the last innovation or area we were going to touch on was adaptive
Yes,
radiation. Do you want to kind of close us out
sure.
with maybe how that connects to some of the other things that we've been
Yeah.
talking about?
So adaptive radiation is kind of more of a new, kind of like area, I guess you can say.
Mm,
Um, so at our center at UT Southwestern, we have a whole adaptive center, and we have many machines, which is kind of unique because these machines are not, you know, they're becoming more readily available in different practices. And I think we're going to start seeing a lot more of it. But basically, what it is normally when we do a radiation plan, we do a CT scan, and then
mhm.
the entire course of treatment is based off of the anatomy on that one day from that CT scan.
Ah,
Radiation. And so, like, imagine if you have a 6-week course of treatment, your anatomy can change. You can lose weight, you can gain weight. If we're
yeah.
talking about breast, you know, it's moving around on a daily basis, you know, just different things, right? Even a prostate
Yeah.
around or a bladder or whatever it is. Things are moving around. We're not like the same person we were today as we will be in 3 weeks or 4 weeks or 5 weeks. But what's amazing about adaptive radiation is every day when the person comes in, we are doing a CT scan on the machine, on the same radiation machine, and we redo the radiation planning based off of the anatomy that day. So, what the power of that is that because we're doing a real-time plan, we're able to reduce the dose to the heart when we're treating breast cancer, to the lungs, to the skin, to the ribs, because if the anatomy has changed and we're not accounting for that, then these other nearby structures are getting higher doses. We were the first ones to publish the experience, our adaptive experience for breast cancer treatments about 2 years. It was like, about 2 to 3 years ago. And we kind of outlined the entire way to do it for these treatments. And our program has just grown. So now we're offering it for like partial breast radiation. We're doing it for whole breast radiation. There was a study that came out of the United Kingdom called the Fast Forward, and they're basically offering whole breast radiation that used to be done in 4 to 6.5 weeks in now 5 treatments. And it
Amazing.
was a phase 3 trial, and they compared it to doing a 4-week course of treatment in 5 days, and they found that, you know, the outcomes were pretty much the same at 10 years. And so this is something that's being done very commonly in Europe, not so
Mhm.
commonly in the United States. But what we've done at our center is we have used that fast forward treatment and in 5 treatments and paired it with adaptive radiation so that we can monitor the heart and the lungs, because we're doing higher doses per day, and just making sure that as the breast swells, because you're giving a higher dose and you do get swelling in those first 1 to 2, 3 days,
Yeah.
that we're accounting for that swelling and the differences in anatomy that are happening, so we can really reduce the dose to all the nearby structures. Um, and so that, I think, is, you know, where a lot of treatments are going to probably move to over the next decade, is doing an adaptive approach and hopefully doing shorter courses of radiation, will
Yeah.
be another theme that we're going to see. But again, kind of trying to make treatments easier for the general public so that there's less what we call financial toxicity on
Yeah.
patients. meaning like the time that they have to take away from work, from their family, the gas, the mileage, all the things, all the treatments, the to and from the treatments. We're trying to streamline that as much as possible. And this is like just one other way that we're able to do that.
That's huge. I mean, all of these things are very inspiring, and it's exciting to hear, that there's constantly new developments and kind of thinking about the long-term life of so many of the patients that are diagnosed so young, too. When you were talking at the beginning about, the side effects long term of radiation in the past, like maybe because of some of this research and innovation, things will be different for people in, 30 years following treatment or something. So this is really, really inspiring. Thank you so much for sharing all of your expertise. We've talked about a lot of studies today. Do you have a website on UT Southwestern or a place where people can maybe go to learn more about your research and your focus? Where would be the best place for people to find you and learn more?
Yeah. Well, yeah. So I have obviously the UT Southwestern has kind of my profile, Asal Rahimi. So ASAL, and then last name is Rahimi, Rahimi. You can email me at asal.rahimi@utsouthwestern.edu. Um,
Right.
Also, usually if you're in the US, if you just do like a Google search, a lot of my research will come up with just kind of some
Wonderful.
preoperative and some of the other trials that I talked about. You can see that on PubMed, or just putting my name in, you'll be able to see a lot of that. Um, and then I think we have one more question, a little off topic, but do you refer patients to a medical tattoo artist for areola restorative tattooing, or is that something your nurses handle in-house? Um, so our reconstructive surgeons, they actually do the referrals to the medical tattoo artist. And I know that at some point they used to have one at UT Southwestern, but I know at another point they were referring out because they didn't. So I'm not really sure what the status is today. But they do get a medical tattoo artist to put those areolas on patients, but I'm not exactly sure. I don't want to talk on their behalf.
That's amazing. And I know AIRS has some great resources as well for different patients in different areas. So just as a reminder, the AIRS Foundation, for anybody that is not aware, provides information, education, and grants to women that are underinsured, uninsured, or in need of reconstructive surgery and resources for their treatment. So we accept grants at all times based on financial need. So thank you so much, Dr. Rahimi. This was so educational, and we will be sharing this on the AIRS webpage tonight. And then we will have this to refer back to. So thank you so much for your
Thank you
time.
so much. Thank you everyone for joining, and I appreciate it.
Have a great night. Bye, everybody.
Bye.